This program is brought to you by Emory University.
Good morning, everyone, and welcome to Heart and Vascular Grand Rounds. Thank you, all of you, for joining. It is truly a privilege to introduce one of our own speakers and one of my mentors here at Emory, Dr. Arshed Quyyumi, who I think everybody knows, but it is still, I'll go ahead and introduce him. He's a tenured professor of medicine and director of Emory Clinical Cardiovascular Research Institute. Dr. Quyyumi also holds Bruce Logue Endowed Chair for Cardiovascular Research. He graduated from Guy's Hospital Medical School in London, and after accomplishing part of his medicine and cardiology training in London, he trained at Mass General and then subsequently at the NIH. He was a senior investigator and director of the cardiac cath lab at the cardiology branch of the NIH prior to coming to Emory. Dr. Quyyumi's research has focused over the past 25 years on various topics related to clinical and translational cardiovascular research in vascular biology, progenitor cells, angiogenesis, biomarkers, and various cardiovascular omics. He's done some seminal and classic papers investigating mechanisms of myocardial ischemia and silent ischemia in the past, and is also focusing now on the role of genetic and environmental risk in vascular disease, as well as social disparities of health. He's conducted clinical trials with bone marrow-derived stem cells and progenitor cells in cardiovascular disease, and published close to 500 manuscripts in peer-reviewed journals. Today, he's going to talk to us about seeking precision in coronary artery disease management. Dr. Quyyumi.
Thank you, Pooja. Thank you very much. Thank you for the opportunity. Let me see if I can. So here are funding organizations and some potential conflicts. I am going to talk about studies that were funded through a non-restricted grant by Abbott Labs and a clinical trial that will be funded by them. So I'm going to begin with some introductory comments as to why we need biomarkers, perhaps, that are different from the ones that we are currently utilizing to be more precise in treating our patients with coronary artery disease. So here's how we think about coronary artery disease. We know that there are a number of risk factors that are commonly well understood that lead to this process of atherosclerosis that changes the coronary artery from being a normal vessel to one that develops atheroma. And then, and that is a pretty silent process, but then when it leads to progression of the plaque so that it causes either severe stenosis or more often a rupture of the plaque or erosion that leads to acute coronary syndromes is where we end up with adverse cardiovascular events of either ischemia, infarction, leading to heart failure, often death prematurely. And the biomarkers that we have used to detect this disease have really focused on all these risk factors. And Peter is here who designed these risk factors and formulae that we now currently use. And when you're looking at normal people, and once you've developed atherosclerosis, these risk factors are not that valuable in predicting risk of further or future cardiovascular events. And we've often resorted to stress testing. Clinically at least, where we hope to be able to identify people who have severe stenoses, and then we go and revascularize these either with angioplasty or stenting and bypass surgery, et cetera, in order to avert these consequences of future myocardial infarction, sudden cardiac death. But we understand that this is not a perfect way of dealing with these people. And of course, we treat them medically. And the reason it's not perfect is this is a follow-up of more than 3,000 individuals who are going through the Emory Cath Lab. We have this, what we call the Emory Cardiovascular Biobank, where people who go through the cath lab routinely, either with acute coronary syndromes or stable disease, et cetera, are consented and they are stored in this database, and their samples are also stored. And they're followed long-term. And this is just showing you 5-year outcomes of this population. There's a relentless occurrence of death, cardiovascular death or myocardial infarctions, almost 17 1.5% of these people, 1 in 6 of them, will have one of these adverse events going forwards in 15 years, despite the fact, in 5 years, despite the fact that we are treating them with usual revascularization the best way we can, medical therapy to the best way we can based on current guidelines. So the question is, in an individual, everybody gets treated the same way, of course. And all their risk factors are taken care of, and they get aspirin, et cetera, statins. And the question is everybody facing this kind of a risk, or is this a very heterogeneous population of variable risk that we can identify upfront so that we can perhaps not only just identify them, but intervene with them? So there is this amazing residual risk in this population who are being managed currently with the way that we do, guideline-based. So we can go back and ask, how do we develop atherosclerosis, and how does the atherosclerotic plaque become unstable and rupture? And we know that these are the processes that are important. So there is increased oxidative stress that leads to vascular dysfunction. That is the primary injury that leads to development of plaque, the infiltration with these inflammatory cells and oxidized lipids and so on and so forth. And I won't go into this just for the sake of time, but we know that oxidative stress, inflammation, immune dysregulation carried out by these cells, and the prothrombotic state that is necessary to lead to clot formation, the damage that possibly occurs to the myocardium either from ischemia or for other micro injuries that might lead to myocardial stretch, etc. So all of these events are occurring, and these are all measurable by circulating biomarkers. And there are a number of them, and there are a slew of them, and I won't go through all of them, but I'm going to concentrate on some that are looking down these different pathways that I just mentioned, that appear to be independently prognostically important, and therefore might be worth considering as ways of identifying people at high risk. So I'm going to quickly go through these, especially the ones like troponin and SuPAR, which are perhaps new for most people. And go through the rest of them very quickly to build up the picture. So oxidative stress is a complex process. As you know, it's mediated by reactive oxygen species that have very short half-lives, very hard to measure. It's an intracellular process, but it signals a variety of different changes in the redox state that can be measured by the circulating aminothiol. And with Dean Jones, who has a very standardized HPLC way of measuring these are circulating aminothiol. We did this particular study, or a series of studies, where we looked at the predictive value of oxidative stress in all sorts of subclinical and clinical cardiovascular disease states. And this work was done, and you'll see these fellows or ex-fellows, some of them, who have done much of this work, and you'll see their pictures on the right-hand side because I'm just using what they worked on to present to you when putting it all together. Riaz, by the way, if anybody remembers him, is now a full professor at University College in London, one of the youngest professors in the UK system. So he was here just about 10 years ago. So oxidative stress increases as we age. When people develop endothelial dysfunction, it's an independent predictor of endothelial dysfunction, of increased arterial stiffness, of increased carotid thickness, of diastolic dysfunction, of worse coronary flow reserve, and also of future occurrence of atrial fibrillation and pulmonary hypertension. So all of these fundamental processes that go wrong with the heart or the arteries can be or are associated with increased oxidative stress. But most importantly, all of that might be of interest, but is that it's the measurement of cysteine and glutathione in circulating blood and their ratio, a high ratio signifying increased oxidative stress, which is the red line, and a low ratio of better oxidative stress. Then if we divide people according to this ratio by a median value, then there is threefold increased risk almost in people who had increased oxidative stress. These are people with coronary disease in our biobank, 1,200 of them, who were followed for about 2.5 years. So an independent risk factor for future occurrence of death and MI in a population after adjusting for all the usual characteristics that we measure, including LV function and coronary disease severity. High sensitivity CRP, which depicts inflammation, is a very well-known marker, so I'm not going to spend too much time, but just to remind you that the vascular wall gets inflamed. It releases all these short-acting interleukins like IL-1, IL-6, etc. They circulate in higher concentrations and make the liver release a series of acute phase reactants. Included amongst them is CRP, and we measure CRP because it's easier to measure. It's a standardized assay, etc., etc., and has become the gold standard for the high sensitivity measure, gold standard for for diagnosing systemic inflammation, but also as a predictor of future occurrence of bad outcomes like MI, death, stroke, etc. So when you compare the top quartile with the bottom quartile, almost 2.5 to 3-fold increased risk of these adverse events if you have higher levels of circulating high sensitivity CRP. What about BNP? BNP is a different marker from CRP. It's commonly used, of course, in heart failure or to detect and to manage. As you know, when the myocardium gets stretched, the pro-BNP, which is inside the myocyte, gets cleaved, and then it releases NT-pro-BNP as well as BNP. These are peptides which are related to pro-BNP. NT being a longer peptide, has a longer half-life, but it's inactive, whereas BNP is an active peptide. And this has a very short half-life. This has a slightly longer half-life and therefore more stable. So we now have cutoffs like 100 for BNP that allows us to say, well, beyond that, we know that there is stretch of the myocardium and there may be heart failure. But all of these things that we're going to talk about are values within the normal range. And even within the normal range, silent LV dysfunction, LV hypertrophy, coronary disease, left atrial enlargement, atrial fibrillation, etc., and even bad hypertension leads to increases of BNP even within the normal range. And in fact, in these mega sort of studies that have done meta-analyses, if you look at the top 10th percentile of BNP in the normal population, and compared to the bottom 0 to 90th percentile population, then there is higher risk, almost 2.5-fold increased risk of having major cardiovascular events going forward or coronary events with high BNP levels within the normal range. Even after adjustment for risk factors, medications, etc., it's still valuable. And then even after adjusting for CAC score, meaning calcium score, these are population-based studies, so there was value in it. What about high-sense troponin? I want to go over data that our lab has been working on for some years now, and not really talk about acute coronary syndromes where we are always using troponins, but in all these other conditions, ischemia, coronary disease, and progression and prognosis that we have now been looking at using this high sensitivity assay. So this is not the regular troponin assay that you use clinically. Okay, that's just C-troponin I. It's the high sensitivity version. So just to remind you, there are several troponins that are bound to actin and myosin, and that inside the myocyte, which I again won't go into too much in detail, but there are 3 important ones that we can that are present: troponin I, C, and T. We are interested in troponin I and troponin T, and there are clinical assays that are commonly used to measure those 2 troponins, only because troponin C can also be released from skeletal muscles, so it's not very valuable for heart disease. So when these sensitive assays, not the high sensitivity, but the sensitive assays that we currently use came about back in the 90s, they were able to detect values about 1 nanogram per ml. But as these assays improved and they became standardized and we started to switch from CPK measurements, CPK-MB measurements to sensitive troponin measurements, then they became much better in terms of the sensitivity of detection that allowed us to then measure the increase in troponin at a reasonable time point around 6 hours, 4 to 6 hours, because it reached a level of detection that was reliable with those assays. But the high sensitivity assays now actually are able to measure down to this level. So they are tenfold more sensitive than the sensitive assays. So that's why it's called high sensitivity. So many places have now switched to this assay, and this is what is now being used clinically. And I think Emory ultimately will have to switch as well because the manufacturers will stop selling the old assay. We can now measure, even in the healthy normal population, some troponin if you use the high sensitivity in more than 50% of individuals, whereas currently, if you take normal people, about 20% of them have measurable troponin. It has a low coefficient of variation, so it's highly precise, and it measures tenfold lower levels than the standard troponin assays that we have. So the value in this in terms of acute coronary syndrome has been that when you have an occlusion of the coronary artery and the infarct starts, chest pain begins, then it takes about an hour or so to start detecting high sensitivity troponin if you use that assay. Whereas clinically now we have to wait to even 6 hours to be sure that there is not going to be a rise in troponin because the sensitivity assay is up here. So that's the role of these in the clinic currently. But if you look at the high sensitivity assay and see how the population distribution of this measurement is, and this is how it is. Based on this, the people have come up with 99% cutoffs so that you can say that above this value, it's abnormal, and below this value is normal. So there are now sex-based cutoffs available for both high sensitivity troponin T and I. And what we are interested in is in this group of people, what is the value of troponin distribution this side of the normal range versus this side of the normal range? And just to remind you again that having a high troponin value, even currently, doesn't mean that you've got an MI. There are all sorts of slew of reasons why troponin can be high, and that has nothing to do with infarction, but is to do with injury to the myocardium, either through heart failure or tachyarrhythmias or myocarditis and so on and so forth. So that's your type 2 MI and non-cardiac troponin. So with that background, I'm going to talk a little bit about what it might do, what high sensitivity troponin might help with in terms of ischemia detection. So these are studies that were done by a series of our fellows. This is Mohammed Hamada. This is a study called MIPS, where we were, as part of a protocol, taking people with coronary disease, almost 600 of them with stable coronary disease, and they underwent stress testing either using treadmill exercise or with pharmacologic testing using regadenoson. So here we measured then troponin, high-sense troponin at baseline and 45 minutes after their stress test, whether it was a treadmill stress test or pharmacological stress test, and then looked at people who had ischemia with exercise. So a third of them had ischemia during treadmill exercise, and they actually had a rise in troponin. Whereas the people who didn't have ischemia had no rise. Similarly, during pharmacological tests, the people who had ischemia didn't have a rise because pharmacological stress ischemia, so-called, is really a flow mismatch. It's not ischemia, whereas this is actually ischemia where the myocardium suffers an ischemic injury. Not only that, there appeared to be a difference at baseline. So people who were ischemic tended to have high baseline troponin levels compared to those who didn't. This is just looking at the magnitude of LV dysfunction and troponin values. Again, when I say troponin, I mean high-sense troponin. So increasing amount of scar, higher troponin values. This is looking at conventional stress ischemia, higher degree or greater ischemia, higher troponin values. So we wanted to see if we can use resting troponin levels and come up with a threshold at which we could detect people who are likely to have ischemia, and more importantly, detect people who are unlikely to have ischemia. Now, remember, this is not the general population. These are people with stable coronary artery disease, so they have some level of coronary atherosclerosis. So again, we did it in 2 different cohorts to be able to find a threshold in one cohort and then look at the second one to see if we can reproduce our thresholds. So here's what we're looking at. In the derivation cohort, we found that people who had no ischemia during stress testing had lower baseline troponin levels than those who had ischemia. And this was reproduced in the validation cohort. So the next step was to see if you can find a threshold or cutoff, which gave us the best sensitivity and the best negative predictive value, so that you can begin to use this as a test to detect ischemia without doing a stress test. So at a value of 2.5, if you go for anybody with any degree of ischemia, then 95% sensitivity and 90% negative predictive value. So what this means is that a level below this, at 2.5 or below, you are unlikely to miss anybody who has myocardial ischemia 90% of the time. So you'll miss 10%. If you say, well, I only want to detect significant ischemia, then the values improve even more, 97% sensitivity and 97% negative predictive value, meaning you're only missing 3% of people who have ischemia by just using this cutoff of troponin. 25% of people had troponin levels below 2.5. So you could take 25% of your population with coronary disease and tell them there's no need to stress test you because you're very unlikely to have ischemia during stress test. But is that good enough? When we followed these people, those who had low troponin values had no events next 3 years, no deaths and MIs, whereas all the events that occurred were in people over the next 3 years, in people who had higher levels than that. So not only is it a good threshold to detect ischemia, but it's a good threshold to predict who's going to have future events. So a low plasma level of high-sense troponin identifies patients with coronary disease who have a very low risk for myocardial ischemia during stress testing and low medium-term risk of adverse cardiovascular. So one could begin to see how you could reduce the use of stress testing, which is astronomical and expensive, at least by using something simple like this. And because we found that troponin levels actually increase in people who exercise and develop ischemia, we also measured the troponin values after exercise, as I showed you, and divided people into those who had an increase in the red lines, more than 20%, and those who didn't have an increase. 2.3-fold increased risk of future cardiovascular events, these are deaths and MIs, in people who had a rise versus those who didn't. Now, if you combine the baseline troponin values with the change in exercise, then you can have a nice gradation so that people in the blue line are those who have low resting troponin levels and don't change their troponins with exercise. And in the brown line, we have people who have high resting troponin levels who have a further increase in levels with exercise. So 4.5-fold increased risk of death and MI going forward in the next 3 years if you have this, if you're in this group versus this group. So very good discrimination of risk based on high sense troponin use both at rest and ischemia. So rest and exercise. So in stable people with coronary disease, high sense troponin elevation with exercise stress testing predicts adverse cardiovascular outcomes beyond traditional risk factors and beyond inducible ischemia. So all these hazard ratios are independent of whether or not they had nuclear ischemia as well. So what about coronary disease? How good is troponin predicting coronary disease presence and severity? So here's 3,000 people that were in our biobank, divided them by their coronary anatomy into those who had normal coronary angiograms, non-obstructive disease, 1, 2, and 3 vessel disease, or by Gensini scoring, which is another way of determining severity of disease. You can see there's this graded increase in high sense troponin level at rest between those who have no disease versus those who have terrible disease. Now, the next question is troponin of added value over and above the coronary disease severity, which we know matters in terms of outcomes. So what you're seeing in this is relative risks of having future death or MI, and then people who have no disease on the right here, and then 3 vessel disease on the left here. So as you can see, as you go from no disease to more disease, you have worse relative risk of having events, as you know. But the added value of being in different troponin tertiles is shown this way. So if you go from front to back, you can see that even in people without any coronary disease or those with non-obstructive disease, being in the top quartile of high-sense troponin gives them 8-fold, 6-fold, 10-fold increased risk of having death and MI, over and above having non-obstructive disease, and similar value even with people with more obstructive disease. So independent value in not only detection of disease, but also in adding to the prognostic value, however much disease you have. So the next question is, coronary disease progresses pretty much in everyone, but hopefully not in everyone, but most people. A lot of our patients come back and have repeat coronary angiograms. So these are frequent flyers. 717 people came back over the next 3.8 years on average. And so we looked at the change in the angiogram, each of the lesions before and after, and calculated the progression rate, right, over time of these individuals. So this is not a design, this is a sort of study that occurred only because we had these angiograms, only because these people were being CATs. So it's not really that everybody underwent repeat CATs. But so you have to take this with a pinch of salt, but nevertheless, what we found was that these are progression rates of coronary disease, this slow progression of coronary disease. These are not acute coronary events. And you can see that if you are in the lowest quartile of troponin, you had much less chance of progression than you had when you were in the higher quartile of troponin, where the progression rate was 3.6-fold higher. So even stable disease progression, not acute coronary syndromes, is faster and more rapid in people who have higher troponin levels. So what about the general population in terms of prognosis? So there are many studies that have looked at this. This is a meta-analysis of 154,000 people. So this is the general population, not people with disease, divided into bottom third and top thirds. And if you compare the two, increased risk of CVD, CHD, fatal CVD, even stroke, about 50 to 60%, if you like, between the two tertiles. But what about people with coronary disease, which is a population we're talking about today? So this is now, again, this 3,000 people study from our biobank where we measured high-sense troponin shown in quartiles here. Notice this amazing differentiation of risk, independent, once again, of all the other clinical measurements that we use. 2.8-fold increased hazard of having death or MI if you are below median versus above median. If you look at quartiles, it's almost 4-fold increased risk. So here we are getting hazard ratios that are really not, they're much stronger than what we generally associate with risk factors like diabetes and smoking. Now, chronic kidney disease is very common in people with coronary disease associated with worse outcomes and all sorts of issues, as you know, which we won't dwell on this time. But nevertheless, out of the 4,000 people, a quarter of them had eGFR less than 60, so they had some element of CKD in our study. So when we divided people into those who didn't and those who did have CKD, and this is a paper written by Pratik, you notice how troponin, high-sense troponin was equally predictive in people with CKD as it was in people with no CKD, but even more so predictive in those who had CKD and coronary disease. It's a stronger predictor of in the CKD population than non-CKD. So it really doesn't detract, even though currently in our clinical use, we are always confused when people with renal failure come up with a high troponin value, don't know what to do with it, et cetera, et cetera. But prognostically, it's still an important prognostic marker. Similar prognostic value in people with heart failure. These are looking at ischemics or non-ischemics, high troponin, low troponin, still predictive. This is not our data, although we have very similar data as well. So in summarizing the value of high-sense troponin in coronary disease, it's high in individuals with more severe coronary disease, increases with transient ischemia, higher levels in those with LV dysfunction and those with inducible ischemia. Low levels are indicative of low likelihood of inducible ischemia, so there may be a cutoff value like that 2.5 I showed you, which might be useful in choosing people to undergo stress testing. Both resting and post-exercise stress, high-sense troponin levels are independent predictors of worse outcomes in CAD. Higher levels are associated with faster progression of coronary disease, and higher levels are independently associated with worse prognosis, both in the general population, those with stable disease, those with heart failure, and those with renal failure. So we have a number of publications, some editorials and reviews that you might Google if you're interested. So the next marker and the last one unique that I want to show data about is SuPAR. And most of you haven't heard of this. SuPAR is a soluble form of urokinase plasminogen activator receptor. So it's a receptor with the GPI anchored to the cell membrane of a variety of different cells. It's expressed on T cells, in endothelium, smooth muscle cells, and particularly in the kidney, in the glomeruli, on podocytes. UPAR, urokinase plasminogen activator receptor, breaks or cleaves plasminogen to release plasmin. So it has a role in thrombogenesis, and it also, the soluble form as well as the bound form are important in a variety of different processes that are listed here. So of interest to us, I guess, from cardiovascular point of view, are fibrinolysis, its role in inflammation, in cell adhesion, and so on, but it has multiple roles, particularly in the kidney that I'll show you briefly. It's ubiquitous in all bodily fluids. It's very stable in its measurement. It's higher in women. So for example, it doesn't go up in acute MI. And levels increase with declining renal function and with increasing age. So in terms of risk factors, it's higher with smokers, with those who are inactive and obese, and hypertension, diabetes, with dyslipidemia, and it increases with ASCVD risk. It's associated with carotid IMT thickness and with arterial stiffness and with increasing calcium score and so on. And when Danny did this study several years ago in our biobank population, we found that it was higher in people with angiographic coronary artery disease compared to those who had normal coronary disease. But more importantly, in more than 3,000 people who were followed up for 2.5 years on average, we found that SuPAR was independently predictive of outcomes. This is independent of CRP and all of the other risk factors that we measure, such that between the top and the bottom quartile, almost 4.5-fold increased risk of having death and MI going forwards. Same data in heart failure. Those people who had heart failure had higher levels of SuPAR, and those with preserved ejection fraction had lower levels than those with reduced ejection fraction. Those with non-ischemic heart failure had lower levels than those with ischemic heart failure. Those with symptomatically worse heart failure, increasing NYHA class, had higher levels of SuPAR. But most importantly, even in the heart failure population, and independent of CRP and troponin and BNP, SuPAR is an independent prognostic marker, so that in quartiles, those in the lowest quartile had much better outcomes, both in terms of all-cause death, cardiovascular death, and hospitalization for heart failure. So again, 2.5-fold increased risk for hospitalization, 3.8-fold risk of cardiovascular death. This is after adjusting for everything: age, gender, race, LV function, use of all the heart failure medicines. We looked at it in the PAD population. So about 17% of our cohort has PAD. SuPAR was 22.5% higher in terms of its level in people who had PAD, and it was higher in people who had more extensive PAD compared to just CAD. And then we looked at its prognostic value, of course. So this is looking at it in tertiles. All-cause death. It was predictive in the PAD population, but also predictive for PAD events. So this is looking at occurrence of amputations, ulcers. This was a study where coronary flow reserve was being measured in 66 people undergoing cardiac catheterization. And so this is looking at microvascular reserve, if you like, with regadenosine or adenosine infusions, measuring flow velocity and measuring coronary flow reserve. So among all the predictors that are clinical, like age, sex, hypertension, diabetes, etc., none of them, including CRP, were predictive of coronary flow reserve. Only SuPAR was an independent predictor and significant. Its real role, actually, in the literature is in renal disease, even though it is a powerful cardiovascular events predictor. People in the kidney field have really been using this for a much longer period and for many other renal-related disorders. It's a pathognomonic sign for FSGS, focal segmental glomerulosclerosis, which is a particular form of glomerulonephritis that affects produces injury to the glomerulus and renal failure. And and then, so when our coronary disease paper was published, Joe Conriser, who is a nephrologist in Rush, who has a lab that has been studying SuPAR for 15 years, called and said, well, can you look at renal function in your population, which is exactly what we did with the help of Salim Hayek. So we had this population, we had measured SuPAR, they all had creatinine measurements, and they had recurrent creatinine measurements over 10 years. So we could draw a line or slope of renal function deterioration in these people over this 10-year period, so that we could divide people into those who had much lower decline in renal function and those who had a much greater decline in renal function based on SuPAR quartiles. So people who were in the higher quartile had much faster deterioration in their renal function, almost 21% decline compared to about 7% decline in those people who were in the lowest quartile. Again, an independent measure of renal deterioration. The only other thing that determines renal deterioration is creatinine itself. As you know, ApoL1 is a haplotype or a genotype that's associated with increased risk of renal failure in the African American population. It's a genotype that has a very interesting occurrence. It only occurs in African Americans. It protects them from malaria and so on. And now we find that it is of a high risk, increases risk independently in this population of developing renal disease. But what this paper showed, and this was also very well received, was that you have to have high SuPAR levels in order for ApoL1 status to give you high risk. So the renal decline was only faster in people who also had high SuPAR levels, both in the Emory cohort as well as in the ASK study where the whole was reproduced. So in summary then, SuPAR circulating levels are associated with CAD severity, with presence of peripheral arterial disease, with adverse CAD and PAD events, with adverse outcomes in heart failure. It's an independent predictor of progression of renal disease and of contrast-induced nephropathy, data that I haven't shown. Again, we have a number of papers on this. If you're interested, you can Google them. So I'll just move on now to ask whether we need to actually deal with these things independently of each other and whether we can combine all of these biomarkers. As you can see, remind you of this figure, there are all these processes that are responsible for progression. What if we combined all of these biomarkers and evaluated them together? So we used hsCRP as a marker of inflammation, of heat shock protein 70, which I haven't shown you data for, as a marker of immune dysregulation, fibrin degradation products as a marker of thrombosis, a SuPAR like we talked about, and for myocardial stretch and ischemia, we use BNP and high-sense troponin. So once again, 3,000 plus people in the biobank cohort. We divided them into a training set and a validation set. And this is work done by Ian Coe, as a statistician. so as to determine cutoffs using the training set and to validate them in the validation cohort. So this is in the training set. Each of these biomarkers was independently predictive using a certain cutoff with high significance. When you had low levels, much better outcomes than when you had high levels. So these are the cutoffs that were derived, and then we confirmed them in the validation cohort. Again, in a model that included all of these biomarkers and included all of the clinical risk factors, each of these biomarkers were independently predictive of each other. Okay, so they are looking down different pathophysiologic processes and they are independently predicting outcomes of each other. So in the validation cohort, we divided people into those who had none of these biomarkers elevated. So that's almost 1 in 5 of the population. Only one elevated, two biomarkers elevated, only 3 and 5 and 6. Okay, so you can see 0 to 6. So when you divide this population who had this homogeneous outcome of 17.5% risk of dying or having a heart attack over 5 years, you can now discover a group that is at extremely low risk, population-based risk, compared to those who have an extremely high risk, much worse than most of the cancers that we treat. So in this population of coronary disease that we treat the way we treat them, are hidden people who have terrible disease, i.e. they have cancer of atheroma, and people who are at population risk level, yet we are treating them with the same intensity and have no idea who's who. And really there was no discrimination of this biomarker risk score in the risk that it was able to determine. In other words, it didn't matter whether you're old or young, male or female, diabetic or non-diabetic, had CKD or no CKD, heart failure or no heart failure, whether you took statins or not, you had the same value for each level of biomarker increase. No heterogeneity. And this is just a different way of showing how low risk the low risk group is and how high risk the high risk group is. And if you like to look at hazard ratios, 11.6-fold higher risk of cardiovascular death and MI. So it's almost like doing a biopsy without doing one to determine who is at high risk. So Ian then went on to combine the value of clinical factors and the 6 biomarkers that we found so valuable. So these were the clinical risk factors that still had independent prediction. And these are the 6 biomarkers. So we have 6 clinical factors and 6 biomarkers to create our equation, if you like, a risk score. And these were heart failure, LVEF, CKD, hypertension, hyperlipidemia, and coronary disease. Note, age is not even here. So age is being accounted for in these biomarkers. So another way of looking at this is of how good this prediction model is to look at deciles of risk. So this is what actually happened. These are people who are divided into deciles of risk, the lowest risk group here and highest risk group. So this is observed risk. What do clinical risk factors tell us? This is what they tell us, the blue columns. So we are overestimating risk at the low end and we are underestimating risk at the high end. But then when we add the biomarkers to it, notice that this is the pink columns, how close we are. So these people who were just using clinical risk factor scores where high risk actually turn out to be low risk. So you're reclassifying risk both at the top end and the bottom end. Another way of looking at risk discrimination is to look at C-statistics. So if you just use clinical risk factors, which we do now, this is the curve you get 1. 70.5 is the area under the curve. If you add the risk prediction model, you get to 77.9. So huge increase in C statistic, highly significant. 33% of people are reclassified from being low to high or high to low. So amazing improvement in C statistic. Just for context, if you just use CRP, there's no improvement in C statistic. So by using a risk score of multiple markers, you get a much better discrimination. The other thing I wanted to show you was if you came in and had all of your risk factors measured and your LV function, et cetera, this is how good our risk prediction is, 70, area under the curve. If you came in and all you had was a 6 biomarker risk score that you walked in with because you had a lab test, then you had better risk prediction. For 72.9 is the area under the curve. So these markers are not only adding to the value of the clinical risk factors, but they're almost as good as having, or better than knowing all these clinical measurements that we currently do. So is this just a quirk of our data set, and can it be reproduced? So we tried to reproduce some of these biomarkers in the Barry 2D trial, where we looked at CRP, HSP, and fibrin degradation products and found exactly the same things. So people who had none of the biomarker elevated had much better risk than those who had 3 biomarkers elevated. There are other studies like the SOMA scan, which is a 9-protein risk score that has been developed in the Heart and Soul study by this company called SomaLogic that use an aptamer-based proteomics approach. It shows the same thing, increased biomarker risk score, increased worse outcomes. Here is a 4 biomarker study in the cohort that had the ezetimibe simvastatin study, the IMPROVE-IT study. They found that each of these 4 biomarkers, 3 of them are the ones that we use, CRP, NT-proBNP, and high-sense troponin, but they added GDF15. And more importantly, they also showed that people who had multiple biomarkers elevated had 2.64 fold increased risk than those who had none of those elevated. So similar kind of data in different studies using different sets of biomarkers. So the risk score based on clinical and biomarker measures is a validated and modifiable risk factor that predicts cardiovascular outcomes. And when we say this, most people say, so what do I do with this information? Why do I need to know this? Because how do I treat a high CRP or high troponin? I know how to treat a high cholesterol and high glucose, but why are you telling me all of this stuff? And even if I found this out, what can I do? So is the biomarker risk score actually modifiable? That's the first question to ask. So in Barry 2D, which did intense medical therapy and lifestyle modification to everybody in that study, and then half of them got revascularized, the other half didn't, then we found that all of these biomarkers were reduced after 1 year of therapy. So medical therapy of the usual kind, and this is a diabetic population, so they also have treatment of the diabetes, improves risk. In fact, of people who started off with high biomarker risk score, almost 80% of them became normal after 1 year, whereas about a quarter of them continued to have high score. Out of people who started with low scores, 90% or so remained the same, but 10% became high over the 1 year. And then if we looked at their prognosis starting at 1 year, the biomarker risk score was again predictive, such that people who had high biomarker risk score continued to have worse outcomes. So they got reclassified based on whatever happened to their biomarkers over time. Here's another study in the IMPROVE-IT study where they looked at the effect of ezetimibe in people with high biomarker risk score. They had much greater absolute risk reduction of 7.3% by addition of ezetimibe only in people who had high biomarker risk, but no effect in people who had low biomarker risk. So you don't need special therapies to improve risk. First of all, the biomarker risk scores are modifiable, but you don't need special treatment. You only need to intensify or optimize therapies that are currently available. Here's the WASCOPS. This is the West of Scotland study, which used pravastatin versus placebo in current disease population, and they followed them for 10, 15 years. And this study is looking at high-sense troponin measurements in this population, showing once again that it was predictive. But more importantly, what they showed was that pravastatin reduced the high-sense troponin level by 13%. And the primary endpoint was 5-fold lower in those with greatest reduction in troponins. So the value of lipid therapy was greatest in people who had the highest high-sense troponin level. So once again, targeting to risk based on biomarkers was better than targeting to lipids. So to these questions, the answer is the biomarker risk score is modifiable by use of guideline-based optimized medical therapy. So the next retort from us physicians is that my patients are maximally treated, so this information is not really applicable to me. So the question is really, are our patients really adequately treated with guideline-based conventional therapies? And as you know, the answer is no, but nevertheless, we all think that we are the best. So this is a 1,500 people study, only just came out in JAMA, who have followed in the current era, 2016 to 2018. Half of them roughly were being managed by cardiologists. And they looked at how optimal the therapy was because these people had coronary disease and they'd had prior MI. And the requirements were that they should be on DAPT for 1 year, high-dose statin, beta blockers for 3 years, and ACE inhibitors if they were a diabetic. So it's not a really high bar. Only 36%, a third of the people were on guideline-based therapy, even in this day and age. And does it matter whether you're taking your medicines or not? People who were not being adherent, and I won't go through just for the sake of time how this study was done, but a large Medicare database, there were worse outcomes than people who were more adherent. So adherence increases or reduces risk, and most of our patients are not adequately treated, even with basic measurements. So the biomarker risk score based on these biomarkers and others is a powerful and independent and modifiable predictor of adverse events in people with coronary disease. And subjects with elevated levels of these biomarkers obtain the most benefit from standard therapy, and optimization of medical and lifestyle intervention and risk factor control is associated with significant longitudinal decline of these biomarkers, and then remeasurement of this risk score after institution of these optimized therapies provides important prognostic information. And a decrease in biomarker risk score is actually indicative of a better prognosis. Now, all of this has been done in retrospective studies. And what we wanted to launch into was a prospective study where we could show that we can take this in a pragmatic setting, meaning in the clinical setting, where we can measure the biomarker risk score, identify people who have elevated scores, and then randomize them into two groups, one that will have optimization of therapy based on their high biomarker risk score until it is normalized, and others who will undergo usual care. So the study is called Precision CAD trial. This was just approved by the FDA and the IRB, and should be launched pretty soon, and would need your help in recruitment and carrying this out. So I'm going to spend the next few minutes just describing this protocol. So the premise for this study is that conventional therapeutic approach recommends use of similar medications at similar doses in all of our CAD patients, whereas this precision approach will be a personalized, patient-centric, precision-based approach using guidance from the multi-biomarker risk score. Because the biomarker risk score identifies not only the low-risk population, but also the relatively high-risk population, and it's modifiable, as I said earlier. So it's a pragmatic clinical trial where people, as I say, will be divided into an optimization group and the usual care group. And our endpoints are normalization of the biomarker risk score, and then further longer-term follow-up for improvement in cardiovascular outcomes. So it's designed as a pilot because, of course, to achieve the events, we would have to have much higher numbers, but its sample size is 250. These are the 4 biomarkers that we will measure: CRP, troponin, high-sensitivity troponin, SuPAR, and BNP. This is the value of this biomarker risk score going from 0 to 1, 2, 3, and 4. We will divide people into 0 who will enter the registry, and they randomize only people with 1 or more biomarkers that are elevated. People will be selected so that they don't have heart failure, so there will be ejection fraction of 40 and above. They'll have to have some atherosclerosis, and they will not be taken after an acute coronary event until they've had a 4-week waiting period. as I said, randomized to those who have a biomarker risk score above 1 into 1-in-1 usual care optimization group. And the optimization group will be seen and have their measurements repeated until if we can normalize their biomarkers. Optimization is with the usual conventional guideline-based approaches, so nothing new, nothing fancy, no canakinumab or any experimental drugs. Intensify lifestyle and behavior changes, cardiac rehab if that's appropriate. LDL to achieve less than 70 in using high-dose statin or Zetia or PCSK9s if required. Aspirin, of course, diabetes, diabetics to get SGLT2 or GLP-1 agents, target blood pressure more aggressively using ACE, ARBs, and ALDO blockers, only if there is EF less than 50, and then further intensifying, as I said, by using PCSK9 or low-dose rivaroxaban in those with peripheral arterial disease, additional of antiplatelet agents if they were on single drug, and using Vascepa in those with hypertriglyceridemia. So that's the study, and hopefully this will move this from just a lot of papers that nobody reads into some practical use where we might be able to move this into the clinic. So that's our hope and goal. This was very fast and furious. There are a number of people who helped produce this data, all our old fellows and our lab coordinators, nurses, etc. And of course, all of you faculty whose patients we have been studying all these years, and many of our colleagues at Emory and outside who have all been fundamentally involved in this, including our funding agencies. Thank you very much for your attention.
Thank you, Dr. Quyyumi, for that outstanding presentation. That was absolutely amazing. I'm ready to measure these biomarkers and modify risk. We have about 1 minute left, but we'll go, while people are asking their questions, type them in the chat box. Tell us a little bit about how we can refer, so this will be from clinic, so not patients who are admitted in the hospital.
No, these will be people that we can recruit who have, say, for example, have undergone cardiac cath, which is why we're recruiting a lot of these people for the biobank anyway. But we can recruit them as long as they don't have an acute coronary event preceding it. Even people who have had an acute coronary event will be ready to be part of this after 1 month. So we will be recruiting from there as well as the clinic.
Okay. I do have a question about the LDL cutoff. For this, it was less than 70 per hour ACCHA guidelines, but it looks like, with European guidelines, they're targeting LDL less than 50.
Yeah.
So that's one question I have.
In diabetics, that's what we will do. I think there is consensus in that population, whereas, as you know, the others are kind of iffy. Guidelines keep changing. We're trying to be very conservative. I mean, even though we are sort of optimizing, and we used to call it intensification, but the FDA didn't like that word. They thought that we should be intensively treating everybody. So we settled on optimization. So there are all these, and nobody wanted us to go do something strange that wasn't guideline based, so that you could say, well, you're doing something that was not what clinicians would do otherwise. So we want to be very careful. And I have a feeling that this will not just, 40% of our patients actually don't take the medicines that we prescribe. And this is well described. So I think telling people that you are at risk like this, even though you've seen your pictures with your angioplasty and your vessel is completely open and now you're back to your normal lifestyle, you really are not at low risk, because we are picking those people who have elevated biomarkers. And so I think it will impact it on that side of implementation of therapies. It's not just the physicians giving the right thing and advice. It's just that most of our patients are rejecting it and really don't feel the reason, because they've gotten away with not doing anything very much for so long. And then time goes by and we keep telling them, you take your medicine and nothing happens to them. And so they get even more reassured that nothing's going to happen to them. And so I think having an extra measure is going to help them target to something. That's why blood pressure works, because they keep measuring it at home, they buy the machines and they go obsess about it. And treatments help if they are guided towards some goal, even from the patient's point of view. So I think this will be impactful not only on the physician side of the equation, but also on the patient side. At least that's the hope.
Thank you. There's a comment from Dr. Sperling. I don't know if Dr. Sperling wants to unmute and ask the question.
Arshed, thank you. Tremendous presentation, and your work over the years has been really inspiring to so many. So what I wanted to ask is, you make a really great case for the study that you're about to embark upon. You haven't gone into the costs and the cost utility of this biomarker risk score, but how about we're seeing right now in the middle of a pandemic, social determinants of health really unmask vulnerabilities in our health and healthcare systems. The future of precision medicine and precision CAD management, what are your thoughts about its effect on health disparities, and if we were to implement this type of an approach?
Yeah, I mean, Larry, thanks for that question. And I often get this kind of a feeling about, okay, now you're telling us to do some more measurements where we are not even measuring blood pressure in everybody under the sun. And how can you justify that when all these people who are not receiving anything? It's a, first of all, we're talking about a population that's at very high risk, meaning people with coronary disease. And we could make the same argument about heart failure, and this whole thing needs to be recapitulated in that population, perhaps also in diabetics. But we're talking about a high-risk population, and it's not meant to be used in the general population. So we're not promoting that or even going there. And there may be a way of doing that in the general population if it's made cheap, but certainly not advocated, because you're going to look for 1 in 500 people who's at extremely high risk. Here we are looking at, 4 out of 6 people have elevated biomarkers, right? So they are the ones that are at elevated risk, and some of them are at extremely high risk. So it's to equate that with everything is probably not fair, because we are focusing here. The other is that the other point is that we, as you know, we have looked in this data, and I presented it before, all the social determinants and how they play an independent prognostic value. So we know that educational level, when it's low, is associated with worse outcomes, independent of all of these things. And the neighborhood matters, depression matters, sleep matters, marital status matters, and so on. So there are all of these social determinants of health that even in this high-risk population have an independent prognostic value. And in fact, they are not captured in our biomarkers. So you're absolutely right that they are over and above the biomarkers. And dealing with them is a separate issue and is not dealt with using this approach. But nevertheless, I think that just because there is, there is a need for that, it doesn't decry the need for this. It doesn't need to be very expensive. We're doing biomarkers, you're measuring blood tests anyway. I don't think this will end up as being a very expensive test, considering how we actually manage these people, which is we're stress testing randomly every time they point to their chest, and then keep looking for something till we can angioplasty something. I mean, all of that is a very expensive approach, and really doesn't save lives. But here you can see what the value of this is. So, I mean, I'm not sure this will be an expensive strategy. You can just look at your baseline troponin and stop doing a quarter of the stress test. Not that it's a guideline, I'm just saying, if this ever became a guideline, we were proposing that as another study, actually, to confirm our findings. Thank you. Sorry, long answer to your short
Thanks
question.
very much.
Thank you, Dr. Quyyumi. Neil Dickert has a question that's, of course, close to my heart, which is that was there a consideration for doing this in people who are intermediate to high risk, but without angiographic coronary disease?
Yeah. Again, I mean, as I said, Pooja, there are people in which this approach is valuable. What I think I showed, and probably didn't emphasize very much, is that the biomarker risk score is not only valuable in this population, right? It's valuable in renal populations, valuable in heart failure, it's valuable in diabetes, it's valuable in people with chest pain, normal coronary arteries, the population that you are interested in particular, because we've actually written that paper, right? A combination of high-sensitive troponin, SuPAR, and CRP was independently predictive of future events. Even though the rate of events is a lot lower in this population, it does identify that top sliver of 5% or 7% of people who had extremely high risk, and you wouldn't know that just by looking at them and measuring cholesterols and things. So yeah, it is. However, you'd have to collect a lot of them because there are very few who are at this high risk. But nevertheless, an approach like this, where you're using conventional treatment approaches and not necessarily looking for a SuPAR antagonist or a troponin antagonist, which is usually the way we think about it. You give me a measurement, you have to give me a drug that goes with it. But what we are saying is that this is actually evaluating risk. The treatment is conventional.
Thank you. Any other questions? I know we're past the hour here. Comments?
Pooja, it's Andy. Just a quick question. Isn't it possible that biomarker testing might actually increase ordering of stress tests when used sort of indiscriminately? That is, somebody gets a blood test, it's abnormal, the patient doesn't have that great of a clinical story, but they get a stress test anyway.
Well, there's nothing here that suggests that that would be the right approach. In fact, revascularization in Barry 2D did not change the biomarkers. So even though we don't say that a lot, but the point is that it does not normalize risk factors, these biomarkers. So this approach of stress testing and revascularization is not the way to normalize these pathological processes that are activating your plaque. The plaques are still activated after the angiogram because it's usually not the plaque that is significantly narrowed. Yeah,
and I agree with that, and I agree that the testing used properly will be helpful. It's also been recognized that high sensitivity troponin testing in hospitals has created a lot of unnecessary cardiology consults and testing. So I would just be a little bit careful saying that biomarker testing is going to decrease testing unless we have really good guidelines around how they're to be used.
You're talking about acute coronary syndrome, admitted people with chest pain and having high-sensitive troponin measurements for rule-outs.
Arshad, I'm really talking about people just getting a blood test and reacting to it without a lot of thought.
Yeah, that's what we
really means.
Go around consulting for. But again, I think this is not, we're mixing apples and oranges. People who are sick and in hospital or presenting with chest pain is not what my talk was about with high-sensitive troponin at all. That is a different, that needs a different talk. And not every institution has found increased utilization of stress tests. In fact, a lot of the ERs have been able to discharge many more people a lot faster, et cetera, et cetera. So it's a whole different discussion, and I hope that people don't get confused by what I'm saying has anything to do with stress testing. Any increase in these biomarkers should not lead to any increased stress testing. There's no call for that.
Right, and that's That's
In fact, a high sense troponin
agree-
value
I
was
agree with
more
that.
valuable with a prognostic marker than the stress test. In fact, it should decrease, if anything, stress testing when used in the right way.
Arshad, I don't know if it's time for another question, but I'll ask it anyway, and you cut me off if not. But first of all, this is fantastic stuff, and we're learning that coronary anatomy is not a great predictor of events. We learned from ischemia that measuring ischemia is not a great predictor, and you're showing us stuff that's predicting events going forward. My question is, do you think all the biomarkers are reflecting plaque burden, which is now kind of the end thing for higher risk instead of ischemia? It's the burden of atherosclerosis throughout the whole system. Maybe not only the amount of plaque, but the quality of the plaque. And if that's true, is there any surrogate of plaque burden like calcium score that could be used as a study group to get a larger sample of patients that could evaluate the biomarker impact?
Yeah, no, that's a great question, Spencer. And, we haven't looked at each of these biomarkers with respect to plaque burden, which, as you know, is pretty hard to compute. But there are now, with the increasing use of CTA and so on, we can attempt to do that. And we are hoping to build up that kind of a cohort in the end, to be able to say exactly which of these many biomarkers is reflecting what. But for example, CRP doesn't look at plaque burden. That's just an example. And I doubt if any of these are really very good measures of plaque burden because of the pathophysiology of how we think they come about. And they are reflecting more of the biological processes that I was referring to, none of which have to do with how much plaque there is. But what they are telling us is how likely is the plaque to become unstable in the near future, et cetera, et cetera. So I think that's how they're working. It also shows this from a multivariate analysis where plaque burden was still, meaning coronary disease severity, was still an independent predictor of outcomes, even when we put in all of our biomarkers. So my suspicion is that none of them are really good measures of plaque burden. And for that reason, I think if we started with, instead of the angiographic population, a CAC population, we would get very similar results. Generally, it tends to be a slightly lower risk population, of course, but nevertheless, I think we'll get very similar results for those reasons. But we haven't done it. We just don't do enough CAC at our place the way we can collect blood to be able to do that.
The preceding program is copyrighted by Emory University.